Okay, hello everyone. Good afternoon, good morning, depending on where you are. I'm delighted to welcome you to the HIV Legal Network's webinar on prison harm reduction in Canada, the second in our Hard Times for Harm Reduction series. Thank you so much for joining us. My name is Sandra Kahan Chu. I'm the co-executive director of the HIV Legal Network, a health justice organization that works to uphold the human rights of people living with and affected by HIV, punitive laws and policies, and criminalization in Canada and globally. We're delighted to have a fantastic slate of speakers today, who my colleague Anne Rochelle will introduce very shortly. The webinar will be in English with simultaneous French interpretation. If you look for the icon for interpretation at the bottom of the screen under the More button with the three dots, you'll see the interpretation button. Please also note that the webinar is recorded. Before we start, I would like to ground us in some acknowledgements. Today, most of us are coming together on this virtual platform from across the land now called Canada, which is located on treaty lands, stolen lands, and unceded territories of Indigenous groups and communities who have respected and cared for this land since time immemorial. At the Legal Network, we work to address the ongoing injustices and resulting health inequities faced by Indigenous peoples. They contribute to the disproportionate impact of the HIV epidemic on Indigenous communities and the mass incarceration of Indigenous people in the prison system. We must also acknowledge the legacy of anti-Black racism and its relationship to criminalization and punitive laws and practices, including on the issues on which we work. We recommit to working towards a more just future for all that respects Indigenous people and Indigenous ways of knowing and being, and to challenging all forms of racism. We must also acknowledge that the meaningful engagement with people with lived and living experience is central to any human rights success, and we pay tribute to people who use drugs in Canada that have harmed by the toxic drug crisis, punitive laws and policies, and everyone who has lost a loved one. I hope we will leave today's event with a sense of renewed solidarity and collective commitment to ending these punitive laws and practices that harm our communities and deprive so many of vital access to care. We will have 1.5 hours for this webinar without a break, and we will have time for the Q&A after the moderate discussions. During the webinar, you'll be able to ask questions in the Q&A chat box. You can also make comments in the general chat. Now I will hand it over to Anne Rochelle to provide some context for prison harm reduction before we move to the speakers. Thank you for joining us.
Thank you, Sandra. Hi, everyone. I'm Anne Rochelle, or AR. I'm a lawyer and a policy analyst at the HIV Legal Network. So we're here today for the second of two webinars focused on harm reduction in Canada. If you missed our first on current barriers to supervised consumption sites, you can watch it online, and the link will be in the chat. Today, we're looking at harm reduction in prison through lived experience, frontline, clinical, legal, institutional perspectives. To ensure we're speaking from a common understanding, we're going to begin briefly by going through what we mean by harm reduction today. And harm reduction begins with a simple premise. Drug use happens, and people who use drugs deserve dignity, health, and safety. Specifically, harm reduction refers to policies, programs, practices that aim to minimize the negative health, social, legal impacts associated with drug use, as well as drug laws and policies. It means working with people without judgment, without coercion, without discrimination, without requiring that people stop using drugs in order to access support. In practice, it refers to a spectrum of interventions from education on safer use, needle and syringe programs, supervised consumption services, naloxone, opioid agonist therapy, or even treatment and abstinence-based options, if that's what a person wants. Because at its core, harm reduction is grounded in autonomy, informed consent, and evidence-based care. In today's context of an ongoing drug crisis in Canada, harm reduction really has to be at the center of all health policies. Since 2016, there have been more than 53,000 opioid toxicity deaths in Canada. The drug supply has become increasingly toxic and unpredictable. At the same time, people who use drugs are disproportionately criminalized and incarcerated. Many are managing substance use disorders in and out of prison, and many enter prison having experienced toxic drug events or experience them in prison. In prison, harm reduction becomes a basic test of whether people can access essential life-saving care. So for many years, the Legal Network has examined harm reduction in Canada's prisons. Most recently, we published Hard Time Persists. in which we assessed healthcare and harm reduction policies and practices across provincial, territorial, and federal prisons. We identified some important progress. For instance, in several jurisdictions, including BC, Newfoundland, Alberta, responsibility for healthcare in prison has been transferred from ministries of justice to ministries of health. That shift has the potential to strengthen accountability, including prioritizing patient health, informed consent, and confidentiality. And we'll hear from some of our panelists about how that transition has unfolded in their own jurisdictions. At the same time, we've identified significant ongoing gaps. And one of those gaps that we will be focusing on today is the provision of opioid agonist therapy, also OAT. While access to OAT in prison has expanded significantly in recent years, we're now seeing a policy and practice shift that risks narrowing treatment with potentially fatal consequences. Our findings, both the progress and the gaps, point to deeper structural questions about how harm reduction can function in prison. So today we're going to be exploring two key themes through our discussions. First, the tension between autonomy and control. Harm reduction is about autonomy, consent, self-determination. Prisons are built around surveillance, discipline, institutional authority. What happens when a model rooted in choice operates inside a system defined by constraint? Second, we're looking at the tension between security and health. Correctional institutions are structured around risk management and public safety. Healthcare is structured around patient well-being and clinical independence. How are decisions made when those priorities pull in different directions? To help us work through these incredibly easy questions, we're joined by a very accomplished panel of speakers. And in no particular order, I will introduce them each. And I'll start with Alicia Gordon. Alicia Gordon is part Indigenous woman, mother, and certified Gladue writer who currently serves as a restorative justice coordinator. She is also working toward her Master Spirit Builder certificate, strengthening her ability to support others using trauma-informed, culturally grounded, and community-centered practices. Alicia brings a unique perspective shaped by her own lived experience with incarceration, substance misuse, and exposure to sex work and human trafficking. These experiences have shaped her resilience and dedication to helping others reclaim their power and navigate complex systems with dignity and hope. Her professional background includes roles as a court support worker, systems navigator, community correctional worker, and research advisor with Lakehead University, as well as offering frontline services to those with substance misuse disorders and housing insecurity. She serves on the board of directors for the Elizabeth Fry Society of Northwestern Ontario. Today, Alicia is a respected advocate whose work centers on healing, restorative justice, and second chances. Thank you for joining us, Alicia. Okay, now we will turn to Anton. Anton is a social worker and manager of all prison programs at Passan, which is a community-based harm reduction program, harm reduction HIV and HCV organization that provides support, education, and advocacy for prisoners and ex-prisoners. He has been working in the harm reduction and HIV sector since 2018, primarily with Indigenous communities and prisoners in federal prisons across the country. Born in Oshawa, Ontario, he is a two-spirit Anishinaabe trans man from Kibawek First Nation and third-generation Irish. His work is informed by a deep commitment to self-determination, liberation, and freedom for all, values which he learned from his teachings and lived experiences that guided him to his professional career and community organization. Now, let's introduce Omar. Omar is an educator, advocate, and community organizer. He is a federal InReach Community Development Coordinator with Passan, who provides day-to-day frontline support and health and harm reduction education and reintegration support to people in federal prisons. As a Community Advisory Council member to the UHN Emergency Department, he advises leadership on service delivery at the intersection of addiction, mental health, homelessness, and gender diversity. Omar brings a multidimensional approach to the panel with over 15 years of professional, academic, and lived experience of HIV and substance use. Omar's work on the Ontario PrEP cohort study in its initial stages, helps to answer important questions about the efficacy of PrEP in real-world settings and reshape our understanding of HIV transmission. Their work and passion, rooted in deep connection to their communities, is centered around addressing systemic barriers rooted in settler colonial praxis on health disparities and gender mainstreaming. Okay, now we'll move to Nicole. Nicole is the executive director of Prisoners Legal Services, a legal clinic that assists people in federal and provincial prisons in British Columbia with the liberty deprivations and injustices they experience in custody. PLS also engages in strategic litigation and advocacy on the prison justice issues brought forward by clients to achieve systemic anti-carceral change. Nicole previously served as PLS's policy director and as a legal advocate before that. Prior to joining PLS, Nicole worked at the American Civil Liberties Union, where she did state-level policy advocacy to combat the school-to-prison pipeline and safeguard and expand the right to vote, including and especially to people with criminal records. She also served as interim executive director of the ACLU of South and North Dakota. Now we'll turn to Jen Smith. Jen has been a social worker for over 15 years in various capacities across the country. Her passion for social justice and harm reduction was fueled by her work with nonprofits in both Calgary and Vancouver and created the foundation for her practice. Now based in St. John's, Newfoundland, Jen works with Correctional Health Services, Newfoundland and Labrador Health Services, at Her Majesty's Penitentiary, which houses provincial and federal men and women. And last but obviously not least, we have Dr. Claire Bodkin, a queer femme family physician and mother living on Anishinaabe territory on the Saugeen Peninsula. Like most rural doctors, she cares for patients admitted to hospital, in the emergency department, in clinic, and at home. She has a focus on care for people who use drugs and queer and trans people. Her research with McMaster University centers around community-driven participatory research methods, the health of people who are incarcerated, and the health of people who use drugs. She has testified at coroner's inquests into drug-related deaths inside jail, co-authored a zine on caring for people who are detained, and contributed to a toolkit on caring for people in solitary confinement being published this spring. She is most proud of her work with the McMaster Prison Health Research Council, where people with lived experience of incarceration shape the prison health research agenda in Ontario and beyond. So thank you so much for our panelists. We're so excited to have you here and to gain from your expertise and experiences. I think I've spoken too much. We're really here to hear from you. So let's start us off with understanding what's happening right now in prison. So from where you sit, what does harm reduction in prison look like right now? And where does it break down? I'll start with a member of Passan, either Omar or Anton.
Yeah, thanks for the question, Air. And Anton, please jump in and fill in any gaps that I may leave behind. But yeah, being on the front line, these are folks that we're interacting with every single day as Passan have access. I shouldn't say we have access, but folks inside have access to us through the phone. And some of the things that we've been hearing is that's impacting day-to-day realities within a prison context is the closure of consumption sites within institutions. We're looking at also the passing of Bill 6, as well as other systemic issues that we are navigating right now, that these things increase barriers to accessing harm reduction supplies within institutional setting, as well as programmings as well. We can also see that how the access to these supplies have a direct impact on prison population, as well as those as well as the transmission of HIV and Hep C within those population, as well as impacting people who are already living with HIV and Hep C within the prison population as well. With the recent changes, I know Claire would probably jump in here as well as other folks on the panel. We are seeing lots of confusion among prison population across the country, particularly as it relates to the new OAT policy and federal cleanup programs, as well as OPS within those institutions. We're seeing a lack of consistency in terms of the implementation of these programs across the institution, as well as the information that is being shared with folks inside institution. It tends to vary from institution to institution. So we're seeing that lack of consistency. We're also seeing a lot of distrust. This is not new information. We know that there's a lot of distrust accessing harm reduction programs inside because of the dynamic that exists between harm reduction, healthcare, and security. We also see a lack of meaningful pre-release programs to support folks, particularly coming from the case management teams inside and parole officers. And at the end of the day, folks come to us, especially our clients, because that huge gap now exists. People are on parole or they're getting out on stat release, and they don't have these support systems and infrastructure to guide them for successful reintegration, and then they end up back in the system. So we're looking at things like basic things such as ID, documents, linkage to care, continuity of care, punitive conditions that they're required to comply to upon release, like abstinence, no drugs, sorry, abstinence from drugs, or yeah, and these are individuals who become or are more increased risk of the negative consequences of a toxic drug supply, as well as recidivism and get back into the system again. So these are some of the things that we are seeing day to day on the front line. Yeah, I'm gonna ask Anton to jump in if as manager of prison programs here, if there are any other pieces that you are seeing that I'm missing here today.
Just to touch base a little more about Bill C6. So with the closure of consumption sites within not just the Toronto region, but the province, and keeping an eye out too of what's happening in other provinces as well in terms of ending harm reduction programming, creating more barriers for harm reduction programming. There's already an impact that is happening inside both at a provincial and a federal level. But one thing that we're keeping our eye out for is the result of a lot of these restrictive legislations being passed are going to greatly increase the transmission of hepatitis C and HIV in both provincial and federal institutions. And already in federal and provincial institutions, they have a very limited capacity in terms of healthcare. Often institutions only have one or two public health nurses on staff, and that would be for an institution of a population of like 300 to 600 people. So when you only have one or two staff working closer to like 9 to 5 hours in order to try and provide prevention, education, as well as treatment to people living with HIV or people who have an active Hep C infection. It just creates more and more barriers and more opportunity for those the transmission to spread.
Thank you both so much. I think that offers us a very comprehensive overview of some of the things that you're seeing through your work, primarily federal in Ontario, right? And I really appreciate the point about how like the legal, social, health context outside of prison are reflected back into prison and vice versa. Next, I'd love to hear from Jen about how she's seeing it from, the institutional perspective. And of course, you're in Newfoundland.
Thanks. Yeah, so in Newfoundland, we have multiple prisons across the province. I work at HMP, Her Majesty's Penitentiary, which is the largest of all of them. Our population is probably 85% remand. We also house provincial and federal inmates here, men and women. Most recently added women. We're extremely over capacity. We have low staffing, so any sort of support or rehabilitation is null at this time. We have very limited space. Our building is almost 200 years old in most of it, and it's just a very, very tight spot. So resources are limited, space is limited. I run programs weekly, and I can fit 7 men in my program room, and there's a lot of men in this jail. So it's really challenging to offer any sort of education, psychoeducation, any sort of rehabilitation programming in here. In addition, the for the drug landscape is changing. The toxic drug supply has finally reached Newfoundland, and we're seeing increased overdoses in the past 2 or 3 years, lethal overdoses that are really challenging to the population that we work with here. And because of the toxic drug supply, we're seeing a criminalization of substance use and mental illness significantly. The population of mentally ill people in our prison has skyrocketed, and there just isn't the resources to be able to support that. And the amount of people we're seeing dry celled coming in from the street, severely intoxicated and in withdrawals, is quite large as well. So in terms of in here, we do have the health authority who manages all health related things in the prison. We are separate from the Justice Department. This happened in 2022, and so far it's been bumpy, but it's been a good transition. We can see the difference between justice and health. We are awarded us a significant opportunity to advocate for our clients from a different perspective, which has been really, really helpful. Yeah, we actually have 2 nurse practitioners, about 10 nurses, a pharmacist, a couple, psychologist, a psychiatrist, social workers. We have a fair amount of health staff within the building, but if you look at it per capita, it's actually not enough by any means. We do have point of care testing, and every single person that comes into the jail is offered to have testing for HCV, HIV, and STBVI. We do initiate HCV treatment here, and we do initiate OAT, offering Suboxone, Methadone, or Sublocade. We try to do it as quickly as possible if someone's coming in withdrawal. And it's been pretty successful, I have to say. Given that 8 years ago when I started here, there was no OAT initiation whatsoever. And the very first week coming from community, I was like, oh, someone needs to get on Suboxone. Let me just call this doctor in the community and I'll hook them up. And I almost got fired for doing that. So it's really nice to see that we actually have a full department now that can immediately get someone on OAT.
Thank you so much, Jen. I find it, I mean, of course, again, we see how like our context, our jurisdictions are reflected back inside of our prisons. And despite the constraints, there is room for positive developments, for more to be done. So thank you so much for sharing that. And Alicia, can we hear from you now about your own experiences?
Absolutely. I couldn't even, I have to echo everything that Jen said. Like what she spoke about are exact representations of some of the things that I experienced. Just for context, I was incarcerated in the provincial system of Ontario, and a lot of the things that I seen, and this is going back a few years now, is like the detoxing on range without, if you're not dying when you come in, you're on your own because of wait lists. So I seen a lot of individuals having to be cared for by other inmates. And that was something that it was even echoed with individuals who had cases of lice. It'd be the other inmates who would be helping them remove those infestations. Another thing that I experienced too is like you come in with this long gambit of medical issues and you're waiting two weeks to see, a doctor. And then when you do see the doctor, because of the amount, the constraints of population to professionals, you're told pick your 3 top priorities and everything else falls by the wayside, which can be really difficult. So you're hyper focused on what can make the biggest difference, and not necessarily addressing each individual problem that has arisen, especially when you're talking about the compound effects of long-term drug use. Another thing that was really interesting that I had a personal experience with, you know, an institution that I was in, I told them I had a broken arm. And, it was something that went by the wayside. It wasn't until there was a security concern that potentially I had been harboring drugs inside my person that I was able to access medical care at a hospital. And it was with my own advocacy. I was like, hey, this is why I'm here today, but I'm pretty sure my arm is also broken. And I was able to obtain the x-ray and the cast that I needed. And that's not a dig at the correctional system. It's just reality that security trumps everything. And it does absolutely 100% of the time get in the way of healthcare. And those are just some of the very small examples. And another thing that I just wanted to echo what Jen was saying is, I have seen in the last few years an increase in services available behind bars, which is an amazing thing to see. But the reality is that we're still lacking mental health, a significant access to mental health. And that really in itself is harm reduction. If we have the ability to get the help we need to deal with the core issues that put us into addiction, that's where we can make change that can make that reentry into community more successful, because we got to deal with the core issues and they're just not at the forefront. Security, then maybe healthcare, and then doing the sentence, and mental health that is the underlying cause of addiction isn't addressed.
Thank you so much, Alicia. I really value what you've said, and I think your examples, in particular, your experience with your broken arm, really, I mean, it's such a great example of this tension that we're talking about around security and health, and it really goes to the core of what we want to achieve. Like, how do we get to a space where these like ambiguously defined security concerns are not trumping someone's like very basic health needs? Nicole, or Claire, do you have a comment?
Sorry, is Nicole next in the lineup? She can totally go, and I
Well,
can go
no,
after. I,
you can both go.
okay. The thing I was just going to say is, as a researcher and a clinician, we don't actually have the data and the research to know. Like, we have all of these beautiful stories and people sharing their frontline experiences. But like, if I wanted to get a number of what is OAT coverage actually like, how many people have opioid use disorder, and of those folks, how many of them are offered opioid agonist treatment within, the first 72 hours that they're in prison or whatever, and do they continue on? Like, we can't get those numbers. We don't have that. So I think that's a real problem. It's hard for us to define the problem when we're not measuring it. And I think there's a lot of concerns that I and most other substance use focused physicians have about the change in the CSC OAT policy and provision. And one of them is that we don't have the data to actually measure the outcomes of this policy change that's being made on the basis of, frankly, very scant evidence. So, yeah, anyways, just to say, I appreciate everyone's stories. Stories are so important. And so, this is the health research geek in me. So is data, and we don't have it.
Thank you so much, Claire. And I think that's a hugely important issue, the transparency. If we don't have transparency, there's no accountability. So thank you for raising that. Nicole?
Yeah, I'll just mention briefly, I'll reiterate what folks have said. We're certainly hearing from clients about the change in OAT policy in the federal system. And with respect to the provincial system, one thing we're keeping an eye on, as others have mentioned as well, is people coming in withdrawal, and people who are really seriously ill. And we're expecting, with the recriminalization of substances that had previously been decriminalized in BC, that this will only get worse. One thing in particular that we've heard in the past that's concerning is that people who are in withdrawal are held in segregation. There is nowhere good in a prison to be in withdrawal. There's really nowhere that is set up for that. But I think it's probably obvious to the folks in this webinar why segregation, would be a particularly sort of harsh and brutal place to go through that. I mean, the reason that folks are put there, as we understand, is that it is the only place in a jail that someone can be monitored 24/7. So that's the reason, and that fundamentally I think is a problem, right? And speaks to all of the kinds of structural issues that you, AR, and the other folks on the panel have been flagging about this sort of conflict between health and well-being and a prison environment. So yeah, I'll just flag that issue that we're watching here in BC.
Sorry, I have so
Thank you.
many things
Oh,
to say, but just
please.
like it is, if you look at the national practice guidelines for provision of opioid agonist treatment and treating opioid use disorder in Canada that were updated in 2024, they explicitly recommend against withdrawal only management. So again, and we don't have the data to say like, here's how many people are coming in and in withdrawal and when they're seeing care, but that is a high risk thing that we do that increases mortality rate. Anyway, I'll try to hold myself back.
No, please don't. These interventions are really useful. And I think one thing that I think everyone has made clear is that the context is becoming perhaps increasingly dangerous. And so there's a need to be proactive and to do more to make sure that we're set up to deal with the harms that are certainly coming our way. So with that in mind, I now want to turn to, yes, Nicole?
Sorry, can I just say one quick thing to
Please.
respond to
Yeah.
there? I just wanted to clarify, like, I'm not suggesting that the healthcare in the BC provincial jails is offering withdrawal management, like that they're not initiating people. I think actually they are making real efforts to get people on as quickly as possible, but people are, maybe coming from police custody, from city cells, whatever, already really, really ill. So just to put that out there.
Awesome. That's good to hear.
Amazing. So let's turn to our next question, which we're going to focus a little bit more on positive stories, bright spots. So I want to ask you, where have you seen healthcare meaningfully prioritized, and what made that possible? And we'll start with you, Alicia.
I'm actually really super excited to talk about this. So, I have to say I was in during the time that I spent incarcerated, I was in a number of different facilities, and by far the most meaningful experience I had was at the Algoma Treatment and Remand Center in Sault Ste. Marie, and I was transferred there to attend treatment. And I didn't even realize that it was an opportunity that was available to me until it was actually a guard at the Thunder Bay CC that was like, hey, there's this program. So I went happily along my way on my journey to attend that. And I will say one thing specifically about programs like treatment behind bars and other programs. They are based on behavior. So to get into that program, you have to be without conflict for 3 months. And correctional systems aren't set up in a way where that's necessarily possible. There was many times where I had to make a choice about in an interaction I was having with another inmate and my desire to go to treatment. And I had to eat crow and I had to take a couple shots to the head to make that goal happen. So that I have a problem with. It shouldn't be based on conflicts. to get into these programs, just because those things are out of our control when we're in those kind of hostile environments. But on the positive side, for me, the harm reduction that came from being able to actually attend treatment was the first opportunity that I had to start planting the seeds for a life in recovery. And that can only happen when there are people willing to plant the seed. So having access to that program was really crucial. Now, I can't sit here today and say that I took that program and then I never used again. That's not the case for me, because we all know that recovery is not linear, and it took a couple kicks at the can, but it set the foundation for the necessary tools around relapse prevention. What was my plan going to be when I got out? Who was going to be my supports? And the advocacy that went through being that program set the foundation for a better chance when I actually was released. And I can't say anything more positive than individuals who are struggling with substance misuse and mental health behind bars being offered those opportunities, because it can create change. If people are a captive audience, it's a really ideal for people to do the work, time for people to do the work, and to lay those foundations, because we're separated enough from our substances that we can start making conscious decisions about what we actually want from life, and we're not being governed by substances. So anytime programming, we need more programming. We need as much as the government is willing to pay for, because that's what makes change. The incarceration itself just causes further harm, but when we can use those opportunities to embrace change, then people have a real shot at recovery.
Thank you so much, Alicia. It's great to hear these positive stories, even though they can sometimes feel few and far between. I think it's a real demonstration of that tension that we were talking about, harm reduction and prison, but an illustration that it is possible to support people, but there are so many barriers left to address. Nicole.
Yeah, thank you. So we've been ragging right on the changes to CSC's OAT policy, but I'll just dial it back a couple of years when and talk about something that I think was really a positive change. When I started here as a legal advocate in late 2016, early 2017, we were getting lots and lots of calls from folks who were either on a super long wait list for OAT, or had been, kind of accused vaguely of diversion and summarily cut off their OAT medication. And so it's a systemic issue that we started doing a lot of work around. Eventually, we brought a representative human rights complaint and assisted, I think, something like 13 people who made their own complaints as well. And we came to a really positive resolution. And I just want to show, if you can pull up the slides. CSC has been publishing data on their website. It recently has been moved to the Open Government portion of the Government of Canada website. But anyway, monthly information about methadone, Suboxone, Sublocade enrollment, and the waitlist. So you can see here, we filed our complaint in 2018, and you can see the problem reflected in the data. As of December 2018, there were 435 people on a wait list for OAT. And the data set is long, so I've just chosen a couple snapshots, but if you can go to the next slide, after our complaint, the numbers started going down, right? The waitlist started going down, and the number on OAT started going up. You can see for yourself if you're interested, but from 435 or whatever it was, it went down and down and down and down. In January 2024, you can see that it was only 65. It went up a bit to 99 in June 2024, and then kind of hovered around the 65 to 100. If you go to the last slide, you can see where we are now. And you can see that as of December 2025, the wait list is only 24. I think that's the lowest it's been. I will flag that it does appear from this data that the total number of people on OAT has gone down. And this, we are kind of interested in whether this is related to the change in sublocade policy.
Nicole, could I interrupt?
Yes.
Would you explain for us what that policy change is in case folks don't really know about it?
Yes. Sorry.
No, no, you're good.
Um, yeah, so starting in September or October 2025, CSC has delisted Suboxone from the drug formulary. So Suboxone is now not available to anyone in federal custody unless a prescriber applies for an individual exemption to the formulary for the patient. And so most people, you can see this in the data too, have been transitioned from Suboxone to Sublocade. Sublocade is the new first line treatment, and with methadone being the second line treatment. So yeah, to Claire's point about data, I think it's still early, right? And there's hopefully more information that we'll be able to see in the coming months. But yeah, I think we are watching kind of what happens to the total OAT enrollment. But anyway, to talk about it as a bright spot, right? I think after the work that we did in around 2020, 21, and 22, CSC really did do a lot of work to bring the waitlist down. We stopped receiving phone calls from people who were on waitlists or who were being cut off. CSC created a position, the National Medical Advisor for OAT, which was a brand new position. And there was some incorporation also of the Mandela rules into CSC policy, which are the United Nations standard minimum rules for the treatment of prisoners. So, those were all really positive changes that we saw. And there's one other thing that I'll also flag on the BC provincial side is that health services in BC provincial jails was transitioned in 2017 from BC Corrections to the Provincial Health Services Authority. And, certainly there are still issues, but we really saw a reduction in healthcare complaints to our office after that transition happened, and a number of improvements to kind of health services overall. Maybe we'll talk a bit later about a bit more about kind of fully independent health services, but that's the second thing I wanted to mention.
Awesome, thank you. And I think we've heard a lot about changing policies. I think it would be helpful if Claire, you're able to speak about what like good oat care looks like as a practitioner.
Yeah, so opioid agonist treatment involves a medication, like an opioid or partial opioid, that is provided to folks with opioid use disorder. And the goal is to treat craving and withdrawal symptoms for 24 hours. So when folks get their next dose of medication, they have not gone into any withdrawal and not had any cravings. There's a number of different medications that are used. The Canadian National Practice Guidelines have buprenorphine and methadone as the two first-line options. And so buprenorphine is the molecule that's in sublingual medication. The name brand for that is Suboxone, and it's the molecule that's in the extended release formulation, so Sublocade. And then methadone is another option for folks, and that was actually a change in the 2024 guidelines. Prior, the last set of guidelines, buprenorphine was the first line and methadone was the second line. But recognizing that methadone sometimes is more effective for people who have very high opioid tolerances, and it has better treatment retention than buprenorphine. The 2024 guidelines were updated to reflect them as both equal first line options. And then the second line option is something called slow release oral morphine, or the name brand is Cadian, which is used sometimes when people have had side effects from methadone or from buprenorphine, or when they find it works better for like comorbid chronic pain, that sort of thing. So we have these medications. Some other important things to highlight about good oat care. So a lot of it, I think, is common sense. It's things people would think about. So it's building rapport with patients, getting to know them as individuals, asking them about what their goals are and where they're at and what they're struggling with, and how have medications they've been on before worked for them, and um, uh, going through their health history, like all of those things, building that rapport and then making an individualized plan with someone. And then coming back to that plan and thinking about, once we've implemented it, like, is it working for you? Is it not working? Can we tweak it? Um, and so I think that's what good oat care looks like, whether you're in the community or whether you're in a correctional institution or whether you're, in a hospital, wherever you are. And that's really reflected in the national practice guidelines. A couple of other things to highlight. So one is that I think for political gain, often harm reduction and treatment are pitted against each other. They are seen as opposing forces, when I think what we know through medical research, through community members and people with lived experience, through our national practice guidelines, is that actually it's a spectrum, and that people need a range of things, including harm reduction, including treatment, in order to like live their best lives and their healthiest lives, and get to where they want to be in their lives. So I think good oat care includes all of those components, and allows for patients to have, individualized plans, to have autonomy, to revisit the plan when it's not working for them, all of those sorts of things. And that can happen everywhere. There was a comment in the chat earlier about, are we advocating for jail as forced treatment or something like that? And I mean, I can't speak to everyone. I don't think so. For me personally, it's not that I think people need to go to jail to heal or recover or achieve their goals. I think it's that because we have jail, because we have prison, there is a duty of care that the government owes people who they are incarcerating, to make sure that they are able to access everything possible that could help them to be healthy and well, both while they're inside and on release. So I absolutely think that people can get care, without going to jail. But since we have jails and since we have prisons, there is this duty of care. And the Mandela rules are one of the things that are our legal obligations. To there needs to be equivalent care for people when they're incarcerated to what they would receive in the community. So much more I could say, but maybe I'll just leave it there.
Thank you so much. Alicia, yes.
I just wanted to echo what Claire was saying too, regarding the comment. So, as somebody who has actually gone through the correctional system, I can see. I would never ever suggest forced treatment on anyone. For me, being already incarcerated, having the opportunity to access the programs only benefited my chances for success on the outside, whatever that looked like. Right. And I think Claire hit the nail right on the head when she's talking about individualized care for individualized individuals. Like, everybody is different. And I do also agree with that relationship of harm reduction and treatment options being merged together, because somebody like me, as an individual behind bars, I really wanted to embrace sobriety. but I didn't have the tools to do that. And even if with the best intentions, I go through the treatment process, I go out, that doesn't mean I'm going to be successful. So understanding how to use safely, where to access services if I'm going to use is critical, and vice versa. Being able to practice harm reduction, relapse prevention, identify your goals as an individual who wants sobriety. You need to be able to have all that knowledge. It's not about picking one path. It's about accessing the information as needed, when things change.
Thank you so much. And Jen, yes, please. Oh, you're muted.
Sorry, we try to see every single guy that comes into this jail, and at 200 plus inmates, that's a challenge for two of us. But we do meet with everybody and do a full assessment on them, and every single one of them, I say, it's not my job to get you off drugs because I don't care if you're using or not. And I used to say to people, like, how do we keep you out of here? And I don't say that anymore because I recognize that some people need to come to jail. They need to come to get off the street, to get out of whatever they were doing. Does it have to be jail? No. But what other option do they have in the community right now to get like a, a stop, a pause, just to figure out, hey, I need to rejig what I'm doing, and I need to figure out, like, this isn't working for me. And I was going out of spiral control on the street, and I needed to just kind of rejig. And it's been really helpful to have that kind of perspective with the guys and to be able to have those open conversations with them, because if you don't want to stop using drugs, that's totally fine. How do we keep you alive? How do we keep you alive so that we can, have you here and have your input here, And so another thing that we've done is created these meetings in conjunction with justice. So all the classification officers, all the health staff, the ODT, the medical, all meet together weekly, and we do release radar, and we go through all the upcoming releases for the next 2 months, and we go through who is assigned to do what, who needs ODT, have they been referred to community, have they been connected with a health professional in the community, do they need counseling services, do they need what, this, that, and the next thing, and we try to figure out for every single person. It's really helpful for the ones that are sentenced and have a release date. We really struggle with the ones that are released from court because we have absolutely no idea that that's going to happen. But it's a good way to kind of be proactive and connect people to the services they need before they get released.
Thank you so much, Jen. Anton?
Yeah, I just want to jump in, echoing so much of what I've heard so far. And I really like the way that Claire framed it. It's not that this is like a great option for somebody in any aspect of their life, but given the fact that this is the way our society is structured and prisons do exist, there is a duty and responsibility from the government, from like Correctional Services Canada, from SolGen, which is the provincial sort of like overseer of provincial institutions in Ontario. There's a responsibility to provide like the best tools available, and through that is programming. And we hear that so much from folks that we work with. And like a lot of the programming that we do at PASAN is focused on whole person health. So we look at mental health, spiritual health, emotional health, and physical health. And boredom is one of the biggest drivers for substance use. And especially if you're in a like, you know, raw, like empty environment and there isn't a lot of stimuli going around. I've worked with people who had spent so many years of their sentence just sleeping and using because there was nothing else to do. And we've seen in the past some successful pilot programs that have happened in corrections, specifically the tattoo pilot. So a tattoo shop was opened up. It was an amazing opportunity for artists, for people who are already, like tattooing is already existing inside. And it's also a really great career path for somebody when they get out. The first person that I ever got tattooed from when I was a teenager was formerly incarcerated. That's where he learned how to tattoo. He had so many amazing stories to share. And we've spoken with people across institutions. Hairstyling is a really, really great, stable career. Those are really great skills that somebody could learn while inside. And it's the fact that there is never really priority put into these meaningful programs. And to touch on like a very specific healthcare one, the PEC program is really, really great. It gives the opportunity for prisoners to connect with other prisoners, to share health-related information in like a trusted way too. We always work closely with PEC workers at institutions. And I think on the books, even, it's a very successful program. The only reason why it isn't as successful is because there isn't as much opportunity or support provided to that program. So going back to limited capacity of a small amount of staff, there's only one or two public health nurses at that institution. They're the ones that are also overseeing the PEC program. Same with committees, inmate committees, the BIFA, Black Inmate Friendship Association, the Queer and Trans Committee. Those are all great committees. And then there's just one staff who is supposed to be overseeing and supporting them. And there's so much transition within institutions too. It's a correctional officer could go from that to a parole officer to a social program officer, and that could all happen within a year. So there's really a lack of continuity, and it goes back to that not allowing people to learn the skills that could really transfer into community again by having some of that autonomy and that decision making and taking on more of those roles. If it's not supported by the institution, if it's not supported by the structure, it's never going to be as successful as it could be. And in ways that it really matters, which is once again, if prisons are supposed to be about rehabilitation, then should it not be giving everybody every opportunity that they can to make a different life for themselves when they're on the outside?
Thank you. Claire?
Um, just thinking about some of the things that have been shared, I do think it's worth us challenging the idea that anybody needs prison, right? Like I think that we collectively owe each other building all of the alternatives, all of the other ways in which people can have their lives affirmed and their dignity affirmed and their like whatever they need to thrive as a person and a community. And I, even in prepping for this webinar as a group, we had some conversations about, well, where are we advocating where we're just actually like further entrenching this system that causes harm versus where are we advocating in ways that like are important for the people that are there now to not leave them behind and lessen harm. I definitely don't have the answers to that, but I think that's worth like thinking about and keeping in mind as we talk about advocating for change in institutions is that it does go hand in hand with building the alternatives as well.
Thank you. And I think in line with that, I'd love to highlight a comment that Lindsay Jennings made, which is just a reminder and something that should be at the forefront always is, and now I quote, people are dying at alarming rates in our prisons and jails due to the lack of harm reduction programming or tools, drug toxicity crisis, negligence, security trumps everything attitude. All of this sounds lovely in a perfect world, but this is not how things play out on the front line for the majority of folks. People are losing their life due to being incarcerated and a drug user. So thank you, Lindsay. I think you're absolutely right and something that we always need to keep at the forefront. And sort of in line with that comment, my next question for you all, and we're running pretty tight on time, so I'm going to ask you all to keep it as tight as you can, maybe 2 minutes. The question is, what would need to shift? What would need to happen structurally, legally, culturally for healthcare to be a real priority in prison? And Alicia, I'll ask you to begin.
So I'll just jump in really quickly. For me, like I'd love to see the diminished wait lists in all capacities, right? When we're talking about accessing healthcare, when we're talking about accessing OAT and things like that, getting people the help they need immediately upon entry into that system. And then also too, again, I can't reiterate how important programming is. And then the last component that I really want to share, preparation when people are exiting. It is so crucial to ensure that people have good exit strategies to support them, whether they're looking at harm reduction or sobriety or just trying to move on with their life. The critical component is beds outside of corrections, safe places to go. So
Thank you so much. Jen?
There's so many things. But we're in a housing crisis here in Newfoundland. We're currently buried under 140 centimeters of snow. There's nothing to do here. The shelters that exist are all run by charitable organizations and are rampant with drug use. When people are released from prison, they are set up for failure. There is absolutely nothing here. In order to get into treatment facility, it's a 16-week wait. There are only 2 treatment facilities in Newfoundland, and they're 21 days long. It's really we're really desperate here in this province to be able to provide any sort of rehabilitation. With 2.5 social workers for 240 plus inmates, it's really, really challenging. Never mind the fact the low staffing from the justice side of it. Oftentimes, there is no rec. Not oftentimes. There hasn't been rec here for a long time. There is no access to anything. A lot of times our programming is canceled because they don't have enough staff to provide the security to make sure that it happens. Guys get locked in for significant points of time. It's horrible. And it's like we're doing what we can in order to give some sort of bright light to or even support, like to even give anything to the guys. And I really feel like the health authority being here has been pushing the boundaries of the justice system in our specific prison to be able to offer any kind of support whatsoever. If there's not enough staff to be able to bring people down for group, then we will have individuals bring one person at a time to come to our offices. We will we will do whatever we can to be able to get people out of their cells, out of their ranges, to get the support that they need. And I have to say that the justice system is working with us very well, as much as they can, to try and accommodate that, because they do, since the shift to having the health authority there, I feel like they do see the value of having us, and see how it can actually help the mental wellness of the building, which helps make their job a little bit less challenging. So it's really challenging here in Newfoundland, in terms of just the bigger picture. When people leave, we often don't assume we're going to see them again, ever.
Thank you, Jen. Hassan, either Anton or Omar or both.
I have one point to share, and then I can pass it to Omar, just to keep it quick. I think seeing a similar model in other provinces about how the provincial Minister of Health and Ministry of Health will look over healthcare in institutions could be at least one step towards providing better care. But also wanting to keep in mind, healthcare on the outside is still rife with anti-Indigenous racism, anti-Black racism, stigma towards drug users, discrimination. And it's the same harms that the most vulnerable people in prison experience, also experience in community. So kind of switching up that a little bit instead, and increasing access to just community-based organizations in general to be providing programming, support services. PSAN is at times a lifeline for some of our clients because we're, especially in federal, especially for lifers, we're one of the only organizations that have a toll-free number that someone can chat to about their healthcare needs. And that, alone, that connection to the outside is something that can always give hope. It can always give a reminder that there is something different available. You just need somebody to believe in you. And unfortunately, within prison systems, there's few and far between.
I'm gonna be very brief as well in the interest of time, folks. I think both Alicia and Anton already echoed some of what I wanted to say in terms of accessing or increased access to healthcare and mental health as well. And all of this come at the intersection of confidentiality of an individual when they're accessing healthcare. And we know that that doesn't exist in corrections. And it's a massive area in which we can build trust with people inside. Yeah.
Thank you both. Nicole.
Yeah. I'll flag two things, and the first is what Anton was speaking to. As I said, BC did transition to the health authority in 2017, and that's something that we'd really like to see the federal system do too. And it would bring the system into line with the UN Mandela rules, which I mentioned earlier, which say that health services should be organized in close relationship to the general public health administration. And so, yeah, from our perspective, truly making health services independent in CSC, taking it out of the mandate of the correctional system, and putting it where it belongs in the health system. And I totally also echo what Anton was saying as part of that, really increasing the access to community that folks have for care support while they're inside. The other thing that I wanted to mention is kind of a rethinking of this diversion term, because I think that drives a lot of decision making. And first and foremost, like, diversion and harm are not the same, right? Diversion is neutral, right? It can be harmful, it can have a neutral effect, it can be helpful, right? Like, if you think in your own life, right, like the time that you might have shared medication with somebody and why you did that. And to my knowledge, there is little, if any, real information, research, data on the question of diversion and harm. So yeah, I think that does drive a lot of policy and a lot of decision making, and it's kind of based on this assumption that it automatically causes harm, when I think really I'm not aware of a real evidentiary basis for that. So yeah, I would advocate really a kind of interrogation of those assumptions, and policy that's truly based on preventing harm, and that harm is people dying, largely.
Thank you, Nicole. And Claire.
Yeah, so agree with Anton. There are these bigger systems that we need to be addressing and dealing with. Healthcare certainly is not neutral or good in a wholesale fashion. And we need to be like building a world where people don't go to jail, don't go to prison, where people can access care. In the more specific sense, agree with what everybody said. We need healthcare to be transferred from corrections to ministries of health at the federal level and provincial territorial level. It would be great if care inside reflected our national practice guidelines on opioid use disorder. That is something of, I would say, like grave concern to, well over 100 physicians practicing and clinicians practicing in substance use medicine in Canada right now, is that they don't reflect the national practice guidelines. Which are, again, not infallible, but are based on a rigorous review of the evidence and guideline development process. And Yeah, there's probably lots of other things. Oh, yeah. Sorry, the last plug I'll make is just as a researcher for good data. We don't have a sense of what, um, yeah, how many people have opioid use disorder, how many people would benefit from opioid agonist treatment, what are the harms of diversion? We know in the community level, buprenorphine naloxone is actually incredibly difficult to overdose on and experience harm from. I think if there is diversion happening in corrections of sublingual buprenorphine naloxone, is that causing harm? Or you know what? You might be scared to find out that it's actually helpful. It's actually reducing people's overdose risk. So I think good data, good research is also a real imperative if we want to see things change.
Thank you. This has been such a rich discussion already, and I want to thank you all for just sharing your experiences, your expertise with us today. We're now going to turn to some questions that we got during the presentation, and if you want to respond, just put up your little hand, and I'll and we can go ahead. So one question we got was, are there positive stories of people who are able to access and get harm reduction supports that were not using an addiction rehabilitation framework? Yeah, go for it, Claire.
Like in corrections specifically, the Drumheller overdose prevention site, I think, is one example. And again, like talking to people that are at Drumheller, it's not perfect, but there was a real culture shift from like correctional unions saying, no, we don't want this. This is a risk to correctional unions saying, oh, wow, actually, this has reduced like issues for our staff, which I know was sort of a conversation in the chat. And then from people who accessed it saying, yeah, it was really helpful for me. It was, a place where I could use safely and slowly and get healthcare if I needed and access new injection supplies and get connected to healthcare when I was ready and treatment options when I was ready. So, yeah, again, I think like, we always need to be thinking about ways of keeping people out of prison and caring for people in the community. But I think that is one example of something that's from a not from an abstinence-based approach that's worked well for lots of people.
Thank you, Anton.
I think this is actually going to just add on really well to what Claire had just shared. So a couple people that I've worked with at GBI over the years have been accessing the PNEP, which is the Prison Needle Exchange program there. And I think very same as Claire said, while the program has a fair amount of hiccups in it, at the same time, it still has been greatly beneficial to some of the people that we have worked with. It gave the security in accessing new drug use equipment, and I think just a little more like I don't want to say safety, but that's how they described it. In terms of their substance use, it felt like a little bit more control was given back to them, and it was able to give them more space and time to put towards their cascading like through the system plan, their sort of like reintegration plan, all of those things. And what they said was feeling more meaningfully like engaged in some of these programs too, like they felt able to. Um, and yeah, I think the same. It just would be amazing if there was more data available that was from an external or like third party doing that research with prisoners to find out their experiences without fear of repercussions, because that's a barrier that we repeatedly see inside.
Thank you, Anton. I don't know if Jen or Alicia had their hand up first. Jen, okay, please, Jen, go ahead.
I do want to highlight the HCV treatment program that we have here that we just started in the past 2 years. It's pretty significant. Like we've initiated over 300 people, and approximately 150 have completed it. It's hard to measure because people go out and recontract and come back, or they continue the treatment in the community, so we don't see the completion. But I think that as a method of harm reduction in our prison specifically is a significant change and really, really good thing for the community.
Thank you. And we, in our hard time report, we looked at that, and it's really not a given that folks will get access to that kind of treatment. So thanks for flagging that, Alicia.
Oh, oh, I was just making sure you could hear me. This is a little bit different. It's more of a security related issue. So I don't know if the situation is current, but there was an opportunity in the past where with advocacy, they were able to remove the strip search associated with accessing methadone or OAT program for the females at the correctional center. And so prior females, they had to strip down and then they would be able to get their medication and then strip down again on the way out. So that was something, so that security component was removed, which I think in itself is a form of harm reduction. We're not actually enforcing people to, bare their bodies in order to get the help they need.
For sure. That would be a huge barrier. And I mean, it was. Thank you for sharing. Jen, is that a current hand? Okay. Thank you so much, everyone. Another question we got is, what are ways that we can support this cause moving forward? What are any actions? Anton.
I would say if there are folks on this call who don't engage with prison or prisoners in any way, like through their professional career, family, friends, close circles, I would recommend like joining a pen pal program or finding out ways that you could even like volunteer by going inside. One thing that I've learned a lot in my time at Pisan was learning from prisoners first. I think there are so many amazing advocacy organizations out there doing really, really great work. But if you're not connected to the people inside, then you can only go so far with that. I've spoken with many prisoners about what freedom looks like to them. And always at some point in that conversation, I'll by accident slip the word abolition. And, I'll be chatting with like so many people, like lifers, and they're like, I don't know what that word means. I'm sick of people saying that word to me. I'm fighting for my freedom. It's freedom. Um, and yeah, I think it's like there's so much like insight, so much like amazing work and words that you can get when you're interacting with prisoners. And I think that's something that's like always important to remember is trying to keep in contact with people. It's designed to be isolating, but there's ways that you can always get around that.
Thank you, Anton. Does anyone else have any actions or ideas for how people can support this cause?
I'll just throw one thing in there, and it's a little bit of a weird action. But if you are going to go participate in programming, inmates love snacks. They love treats. Bringing them with you, make them smile. Another thing I want to add is that it's important for the individuals who are offering support and who are offering program that we're pouring those seeds of hope into the inmates, right? That's our responsibility, is to make them believe that there's still an opportunity, there's still chance that they can thrive in life, and just offering that people need community and they need connection, and the community connection brings the hope where people have a better outcome.
Thank you so much. Yes, Nicole.
Yeah, I'll just add, that I spoke a bit about the United Nations Mandela rules, and I can put it in the chat in a moment. But I think advocating for, the full and meaningful, adoption of and bringing our systems in Canada, our prisons and jails into line with the Mandela rules is a really important, there are a variety of ways that can be done, but it speaks to, as I said, the independence of healthcare, to solitary confinement, which persists, in probably all prisons and jails, including in CSC, to the ethical responsibilities of health providers in prisons. So I'll put in a plug for that.
Thank you. Anton.
I forgot this one last part. And a really great place that you could even start by hearing the voices of prisoners is Pasan's quarterly health resource cell count. You can find PDFs of every issue on our website. You can also subscribe. Cell count is free for anybody who is incarcerated or has been incarcerated or has friends and family that are incarcerated. If not, we do ask for a donation, very much pay what you want. Um, and I can maybe even like pop a link in the chat or something.
Thank you. Yeah, cell count is cool. Omar.
Yeah, just very quickly, I know that it's not a lot of us out there that's doing this work, prison work. And I know like if you are a part of an organization that have an interest in doing this work with us here today and would like to learn more of, getting involved with prison, I would suggest reaching out to us at here at Pasan. Soon we are going to be starting, and Anton, correct me if I'm misleading folks here. We're going to be starting a service provider training so that you are able to get the tools and knowledge you need to go into the institution to do this work if you are now starting out.
That's really cool. Thanks for sharing, Omar. We probably have time for one more question. Um, okay, so we have one here about barriers in accessing OAT and other harm reduction and healthcare services. This person is curious if those barriers are due to management of the federal or provincial facilities or correctional services unions, i.e., is it about formal policies and regulations or resistance to implementation by frontline correctional staff? Anyone have any thoughts? Yes, Nicole.
Well, I mean, I can't speak to I think that probably it's often going to be a combination. I mean, I think in the case of CSC's OAT program, for instance, I mean, there is a policy change, right? That is a clearly articulated policy change that we're concerned about, specifically the delisting of Suboxone. But I think also, it's all of these decisions are being made in a broader context. And I know, for instance, the medication lines were quite long for Suboxone and methadone. I wouldn't be surprised if, the frontline correctional staff were not huge fans of that. There was, more kind of diversion prevention work for them to do. Um, that's in anything that we've seen, from CSC that's not a specific reason that's been given. But yeah, I mean, we do know that on the ground, right, we hear from clients a lot, just in general, not specifically related to OAT, but that, your access to healthcare is mediated by the correctional staff, right? So if you are having chest pains or you're feeling suicidal or whatever it is, and in most institutions, you can't just get up and walk over to healthcare, right? Like you need an officer to take you seriously, like you need to share some pretty personal information, right, in order to get access to healthcare. So I think that, and the way that that happens on the ground, we hear from clients, right, that that often they're not taken seriously or they're not given that access. So I think that is kind of always going to be a big piece of any any policy, and that even a fantastic policy on paper, right, like is subject to those sort of institutional culture things that really do not emphasize dignity and autonomy for people in custody.
Thank you, Nicole. Jen, last comment.
I just wanted to say that I think here, given that it was a justice run health program for so long, and most of the health staff from justice transitioned over to the health authority, was really helpful because those relationships are already there. And so I don't feel like there's that many barriers to accessing healthcare in our specific facility because of those relationships built. So if somebody's in withdrawal, it's not rare to hear a CO call the ODT clinic and be like, "Hey, can you come see this guy?" And if someone comes to the hatch and asks to see medical, 99% of the time it's called immediately and someone is able to be seen. So I think that the basis of having those relationships is really important in terms of accessing healthcare within our facility.
Thank you. And thank you all so much. I'm going to pass it over to Janet now, who's going to close us out.
Hi all, my name is Janet Butler McPhee. I'm the other co-executive director at the HIV Legal Network, and I just wanted to take a minute to thank all of our panelists and all of you for spending this hour and a half with us to discuss harm reduction in prisons. We know this is a really important issue for many of you, and a really important issue for us at the HIV Legal Network. And we promise you that we'll continue to work together with our partners to center lived experience and also evidence towards progressive drug policy for all people, including people in prison in Canada. We do this because we know that while prisons continue to exist in our society, they have a duty to uphold the right to health, particularly for society's most marginalized people. If you have any further questions, or if your question wasn't able to be addressed, please don't hesitate to reach out to us at info@hivlegalnetwork.com. I'm sure one of my colleagues will put that in the chat. You can also keep in touch with us by visiting our website and joining our bilingual legal network news. That link will also go in the chat. I want to say that we're grateful to have received funding from the Public Health Agency of Canada, but of course note that the content of this webinar doesn't necessarily represent their views. And we'd really appreciate if you would take a couple of minutes, just 3 to 4 minutes, to fill out a quick evaluation so that we can continue to hold these spaces so that we can come together. Thank you again, and please take good care of yourselves and your people.